I'm going to talk on Inclisran. Is it emerging as a competitor for PCSK9 monoclonal antibodies, that is evolocumab and alirocumab? We'll say what is Inclisran, we'll look at it, and was it its safety and efficacy in lowering LDL cholesterol and ASCVD events, and what are its advantages over PCSK9 monoclonal antibodies, and does it help in breaking the barriers in population-based prevention of atherosclerotic cardiovascular disease? Now, Inclisran is a small interfering RNA molecule. As seen here, it acts inside the liver cell. It prevents synthesis of PCSK9, unlike PCSK9 monoclonal antibodies, where it acts Inclisran with the GalNAc is specifically targeted to enter the liver cell at this surface with the help of AGP receptor. It enters the cell. It combines with the RISC, that is the RNA-induced adenosine complex, and this compound degrades the PCSK9 messenger RNA. That results in less synthesis of PCSK9. Because of less PCSK9 in the circulation, you will have more LDL receptors and you will have LDL cholesterol reduction. Now let us look at the safety and efficacy studies of Inclisran. Inclisran went through a developmental program, and we have what is called Orion, and we have about 12 studies here, almost a full cricket team with the 12th man. And the name Orion was derived from a hunter in Greek mythology. And even a constellation in the sky has been named after this hunter, Orion. Now we look at this Orion 9, 10, and 11 overview because these studies will tell us the safety and efficacy of Inclisran. Orion 9 had patients of heterozygous familial hypercholesterolemia. Orion 10 had patients of atherosclerotic cardiovascular disease, and Orion 11 had patients of atherosclerotic vascular disease or risk equivalence. This was a 18 months treatment and observation. They had a common study design. The Inclisran was administered 300 milligrams subcutaneously on day 1, then a booster dose at 3 months, that is day 90, and then twice in a year, that is 6-monthly interval. The baseline characteristics of this population was similar. Please also note that 92% of these patients received statins. So if you look at this LDL change over time, the LDL came down by 50% at the end of this study, and the absolute level of LDL cholesterol was reduced by 52 milligram per deciliter. So very effective reduction of LDL cholesterol. It also showed reduction in PCSK9 by 80%. It reduced total cholesterol by 32%. It reduced non-HDL cholesterol by 46%. It reduced ApoB by 41%. If you looked at the percentage of participants reaching LDL level of more than 50% reduction from baseline, it was seen in 61% patients receiving Inclisran and only 2.2% receiving placebo. When you looked at the patients who were statin intolerant, there were about 250 patients of statin intolerance in these patients who received only Inclisran, and there was 68% reduction in their LDL cholesterol. When it comes to the treatment emergent adverse events, there is no difference between Inclisran and placebo, except the injection site reactions. That too, most of them were quite mild. There is no evidence of liver, kidney, muscle, or platelet toxicity between Inclisran and placebo. So there is no safety issues at all. So summarizing this overview of pooled data of Orion 9, 10, and 11, where patients received only a twice-a-year dosing, the PCSK9 levels came down by 80%, LDL percentage reduced by 50%, and absolute LDL cholesterol level was down by 55 milligram per deciliter. And there are no safety issues at all in these 3,655 patients. There's similar safety profile between Inclisran and placebo, except for the modest excess of injection site reactions. There's a pre-specified exploratory analysis of the cardiovascular outcome in from Orion 10 and 11. Death, MI, stroke were reduced. It was the 7.4% in Inclisran, whereas for 10.2% in placebo, and there was 3% absolute reduction with Inclisran. Now we'll be interested in looking at this study where Orion 4, where there are going to be 15,000 patients with more than 55 years of age with atherosclerotic cardiovascular disease who have LDL of more than 100 milligram per deciliter with standard treatment. And we'll be looking at the primary endpoint of cardiac death, MI, stroke, and urgent PCI. And we are waiting, probably we have to wait till 2023 end to get the results. If you looked at the individual patient responses to Inclisran, if you look at the PCSK9 levels, all of them had lowering of PCSK9 levels in their circulation. And when it comes to LDL cholesterol, almost all had decrease in LDL cholesterol levels. Now let us look at some of the barriers to population health when it comes to lipid lowering in atherosclerotic cardiovascular disease. There are many points, but some of the important points are one pertains to physicians, that is awareness and inertia. Other one pertains to patient, where it is cost and side effects, and basically it is around adherence and intensity of LDL lowering treatment. When it comes to statins, the number one reason for declining statin is the worry about side effects. When it comes to PCSK9 inhibitors, which you heard from just now from Dr. Dalal, even with the results of Fourier study and Odyssey study, the needle has not moved at all. There is no improvement even in the approval rate for PCSK9 or in the volume of use of PCSK9 inhibitors. And probably the reason is the pocket costs are too high for PCSK9 inhibitors. So with these factors, adherence is likely to be poor. And one of the studies where they looked at 3 lakh patients with ASCVD, they saw that only 64% were adherent to their lipid lowering therapy. Now, adherence to daily dosing regime remains a challenge, and poor adherence is associated with adverse outcomes. It is an interesting fact to remember that the ideal thing is, of course, high intensity treatment and people are adherent to the treatment, they will have the maximum benefit. Whereas interesting to note that even patients who have taking low intensity lipid lowering treatment, but they are adherent to the treatment, they will have better results compared to high intensity treatment who are not adherent to treatment. So as the adherence drops, the mortality increases and the survival decreases. So how can we achieve better lipid management at population level? We need to improve the clinical inertia. We need to combat the misinformation, and we need to ensure that therapies are affordable. Without improvements in medication adherence, optimal prevention will never be realized. Now, the impact of LDL cholesterol lowering strategies, let us see on adherence and LDL reduction. If someone is taking high potency statins, he has to swallow 365 pills in a year, that is 1 pill every day. And see, the adherence is lower. LDL cholesterol lowering is also less. When it comes to PCSK9 inhibitors, where the patient receives about 26 injections in a year, the adherence shows improvement. The LDL cholesterol lowering also shows improvement. When it comes to Inclisran, the small molecule, small interfering RNA molecule, where it is given only twice a year, the adherence increases significantly and LDL reduction also increases significantly. So the unmet need for our new therapies, we need to move from new drugs to new strategies. Apart from additional LDL cholesterol lowering, what we require is additional LDL cholesterol lowering, which must be maintained. That is important. And Inclisran fits the bill fairly well. So, Chairman, ladies and gentlemen, in conclusion, Inclisran is the first cholesterol-lowering small interfering RNA. It achieves durable and potent LDL cholesterol reduction with only 2 injections.
Sir, 1 minute left.
Small dose and regime for all patient populations for renal and hepatic impairment or familial hypercholesterolemia. It has excellent safety profile in high-risk population, and administration by a doctor coincides with typical 6-monthly patient visits. It lends itself to routine clinical practice, ensuring adherence. So Inclisran is a worthy and a tough competitor for PCSK9 monoclonal antibody. Thank you.